స్టార్ట్ చేద్దామా? 2 minutes వెయిట్ చేద్దామా? పెద్దాయన రావాలా? మోహన్ రావు గారు
సార్ గుడ్ మార్నింగ్. చెప్పండి సార్.
పెద్దాయన రావాలా? స్టార్ట్ చేద్దామా?
పెద్దాన్ని ఎక్కడ ఉన్నారు? కనెక్ట్ అవుతున్నారు.
అవలేదు కదా.
సార్ మీ గురించి వెయిటింగ్. పర్లేదు స్టార్ట్ చేసాను అయితే.
స్టార్ట్ చేద్దామా?
స్టార్ట్ చేశాను సార్. సార్ ఏదో ఫోన్ లో ఉన్నారు, జాయిన్ అయిపోతారు.
Good morning, all of you. Today, Dr. Suresh is the consultant in anesthesia and critical care, Pinnacle Hospital, Visakhapatnam. He is going to talk on gas exchange and ventilation-perfusion relationships in lung. Suresh, I think he will do a good job of making the relationship between the lung and heart better. I request Dr. Suresh to start the presentation.
Thank you, sir. Good morning, everybody. So this is my topic. So my topic is based on this article, which was published in European Respiratory Journal a couple of years back. So my outline of the topic is hypoxemia and its causes. I will be talking about ventilation-perfusion mismatch and what is its relation to specific conditions, and in brief about hypoxic pulmonary vasoconstriction. So we know gas exchange involves transport of oxygen to the blood and removal of carbon dioxide from the blood. So this is facilitated by lungs, heart, blood vessels and blood together. So we know that trachea divides into the right and left main bronchi, and these bronchi in turn divides and subdivides into bronchioles, and after repeated about 17 generations of divisions, these bronchioles end up in what we call gas exchange units called alveoli. These alveoli are perfused by a rich capillary network. So there are about 300 million alveoli in our body, and the total surface area of these alveoli are about 140 square meters. That is roughly about the size of a tennis court. And this pulmonary gas exchange is a continuous process of ventilation, diffusion, and perfusion. And when low VQ ratio regions exist, oxygen is seriously affected more than carbon dioxide. But when high VQ ratios develop, CO2 is the more affected gas. So this is the oxygen transport pathway. So this is the schematic representation of lungs. So oxygen diffuses from lungs into the blood and reaches the systemic circulation. And from systemic circulation, it diffuses from capillaries to the tissues. So this is a schematic representation of an alveolus perfused by a capillary. Here you can see mixed venous blood entering the capillary, gets oxygenated in the alveolus, and oxygenated blood goes out as end capillary blood. So hypoxemia. What is hypoxemia? Hypoxemia is decreased oxygen tension in the arterial blood. So whenever body encounters hypoxemia, it has compensatory processes. To overcome this hypoxemia, the first process is the tissues simply extract more oxygen from the blood to restore oxygen flux. So as a result of this increased oxygen extraction, there is a more severe drop in arterial oxygen tension. And the second compensatory process is to increase ventilation. Hyperventilation is especially effective in returning arterial PCO2 to normal than restoring PO2 in arterial blood because of the linear shape of the carbon dioxide dissociation curve. And the third available process is to increase cardiac output. Increase in cardiac output mitigates the fall in arterial oxygen tension because it allows less oxygen extraction in the tissues. as well as this compensatory tactic will also work to reduce venous PCO2 towards normal, which in turn helps normalize arterial PCO2. So this is you're all familiar with this picture. This is an oxyhemoglobin dissociation curve. Here on the x-axis, we have the partial pressure of oxygen in millimeters of mercury plotted against the hemoglobin saturation in percentage. So normal oxyhemoglobin dissociation curve is sigmoid shaped curve. So the normal arterial oxygen tension is around 100 millimeters of mercury. So this corresponds to a saturation of 100%. On the right, you have the oxygen content as well. So the normal oxygen content in arterial blood is around 20 milliliters per 100 ml of blood. So this 100 millimeters of mercury of PO2 falls to around 40 millimeters of mercury in mixed venous blood, which corresponds to a saturation of around 75. And it corresponds to a oxygen content of 15 milliliters per deciliter. So below this, you can see further drop in oxygen and partial pressure or oxygen saturation results in a precipitous fall in oxygen pressure, partial pressure. There will be a steep decline. So what are the causes of arterial hypoxemia? All the causes of arterial hypoxemia can be grouped into 5 headings. So it can be either due to reduced inspired oxygen tension, hypoventilation, ventilation-perfusion inequality, diffusion limitation, or shunting. So I will be discussing each of these causes with case scenarios. In the first case, we have an elite cyclist who is undergoing cardiopulmonary exercise testing and develops progressive worsening arterial hypoxemia with increasing workload. An ABC done at the end exercise revealed a pH of 7.18, PaCO2 of 30, PaO2 of 81 millimeters of mercury, and a saturation of 88%. So what explains his hypoxemia? So to explain, to understand this, we should learn about a single unit lung model. So it is nothing but we make some assumptions such as that lung is a homogeneous structure and the inspired and expired gas volumes are identical. Blood leaving the alveoli and entering the pulmonary veins reaches the systemic arteries without changing oxygen concentration. So this is a schematic representation of alveolus perfused by a capillary. So the mixed venous blood enters from the left, and once it gets oxygenated, it leaves the alveolus from here. So we'll see what happens to oxygen delivery as well as carbon dioxide removal in this single unit lung model. So on the left side, see the inspired oxygen tension is around 150 millimeters of mercury, which drops to around 100 millimeters of mercury in the alveolus. So the mixed venous blood enters from here, and it has an oxygen tension of 40 millimeters of mercury. Once it reaches the alveolus after getting oxygenated, it reaches the PO2 increases to 100 millimeters of mercury, which is identical to the alveolar PO2. So the time taken for the mixed venous blood in the capillary to get oxygenated and leave the alveolus is less than half a second. So the normal red cell transit time in pulmonary circulation is between 0.25 seconds and 0.75 seconds. If you can see, this is the partial pressure of oxygen on the y-axis. This is the time on the left axis. So from 40 to reach 100 millimeters of mercury for the PO2, it takes less than half a second in the capillary. So what happens to the carbon dioxide? So the mixed venous blood has a carbon dioxide of 45 millimeters of mercury. Once it enters the alveolus, some of the carbon dioxide diffuses into the alveolus. So the PCO2 in end capillary blood drops down to 40 millimeters of mercury. Again, for this to happen, it takes a little more over half a second. So the cause for hypoxemia in this cyclist during exercise is diffusion limitation. So what is diffusion limitation? Whenever anyone exercises, there will be increased oxygen extraction from the systemic circulation. This reduces mixed venous oxygen tension. As a result, there will be increased uptake in the lungs. And because of increased cardiac output as due to exercise, there will be reduced transit time for the red cells in the pulmonary circulation. So the combined effect is there will be less time and more oxygen needs to be taken up. So as a result, these people develop hypoxemia. And it can be seen in normal individuals also who are exercising at high altitude. And diffusion limitation is also the cause for hypoxemia in certain interstitial lung diseases. And usually it corrects with supplemental oxygen. So again, in health and at rest and at sea level, the red cell requires only about 0.25 seconds for equilibration. The available transit time is about 0.75 seconds. Failure of equilibration is therefore not seen in healthy subjects at rest, and this remains so at rest even at altitude. However, during exercise at sea level, failure of equilibration is frequently observed, especially in athletes who have high rates of blood flow and thus lower red cell transit times. At altitude, exercise results in failure of equilibration in essentially everyone, not even athletes, even normal people who are exercising at altitude develop hypoxemia. Why? Because this is due to the reduced PO2 diffusion gradient stemming from the inspiratory hypoxia, especially combined with reduced transit time. So the same graph is represented in people who are exercising at sea level. The solid line is represents individuals who are exercising at sea level, and the dashed line represents individuals who are exercising at altitude. See, as you can see, the in individuals like athletes who are exercising at sea level, the PaO2 doesn't rise to 100 millimeters of mercury as it is supposed to be. So there will be increased alveolar arterial oxygen difference in partial pressures. Similarly, in individuals who are exercising at altitude, this drop is further aggravated because one, there will be a decreased inspired oxygen tension, and two, because of reduced red cell transit time, as well as increased oxygen extraction at tissue level. So coming to case 2, an 82-year-old female who is a known case of chronic kidney disease on continuous ambulatory peritoneal dialysis was suffering from whooping cough. So she was advised a narcotic antitussive for her cough. Upon using this, she became drowsy and unable to manage her CAPD routines. An ABC done revealed a pH of 7.17, PaCO2 of 77, and a PaO2 of 45 millimeters of mercury. This old lady has both hypercarbia and hypoxemia. So how do we explain this? The reason for the hypoxemia and hypercarbia in this lady is because of hypoventilation due to the narcotic antitussive. So the alveolar PO2 in our single alveolar unit is influenced by oxygen delivery, which is nothing but ventilation, and oxygen removal, which is nothing but blood flow, cardiac output or pulmonary blood flow. So hypoventilation and a normal blood flow results in a VQ mismatch. It results in a low VQ ratio, that is less delivery and unchanged removal of oxygen, which lowers the alveolar PO2 and consequently uncapillary oxygen tension. So the not only alveolar PO2, alveolar PCO2 is also determined by the VQ ratio. So a decreased or a low VQ ratio results in a higher alveolar PCO2 and arterial PCO2. If the hypoxemia is due to hypoventilation alone, then the alveolar arterial oxygen gradient is normal. While supplemental oxygen can correct hypoxemia, if the hypoventilation is not addressed, it can result in severe hypercapnia. So this is a graph plotted with ventilation on the x-axis against partial pressures of either oxygen or carbon dioxide on the y-axis. So this dashed line represents the normal ventilation. It corresponds to about 4.2 or 4.4 liters per minute of alveolar ventilation. So at this, if the alveolar ventilation is normal, the alveolar PO2 corresponds to around 100 millimeters of mercury, while the alveolar PCO2 is around 40 millimeters of mercury. If for any reason, like in our case, because of narcotics, this lady developed hypoventilation, the ventilation falls, you can see the CO2 gradually increases corresponding to corresponding to the drop in ventilation. Similarly, the PO2 also drops. The converse effect happens in case of hyperventilation. In case of hyperventilation, even though the PO2 increases, after a certain point, it reaches plateau. Similarly, the PaCO2 keeps falling down with increasing ventilation. So the next case is case 3. A 21-year-old mountaineer notices that her fingers are blue and her saturation is only 65% while climbing. So what is the reason? At altitude, we know that there is a drop in barometric pressure. So the decreased barometric pressure causes a proportional decrease in the inspired oxygen tension, which reduces the alveolar PO2 and causes hypoxemia. As a result of hypoxemia, the respiratory drive increases, causing hyperventilation and increasing total VQ ratio and oxygen delivery to the alveoli. As a result of hyperventilation, hypocapnia develops. Similarly, in this case also, the alveolar arterial oxygen tension difference is normal. So the reason for hypoxemia in this mountaineer is low inspiratory oxygen pressure. So case 4, a 67-year-old female has severe emphysema. Her ABG showed a pH of 7.35, a PaCO2 of 55, and a PaO2 of 55 millimeters of mercury. She has both hypercarbia and hypoxemia. With supplemental oxygen at 3 liters per minute, her saturation improved from 87 to 93%. So to explain this, we need to move from single unit lung model to 2 unit lung model. Here we have 2 units, one with relatively well ventilation as well as well perfusion. The other is the unit on the right have a reduced ventilation because of some obstruction proximal to it, but relatively well perfusion. So the unit on the left has a VQ ratio of 2. So the alveolar PO2 is around 180 millimeters of mercury and alveolar PCO2 is around 35 millimeters of mercury. So the mixed venous blood enters from here, gets oxygenated, and carbon dioxide also removed. So if you sample the blood from here, from this unit, the end capillary oxygen tension is almost similar to the alveolar PO2. So that is 118 millimeters of mercury because this is both well ventilated and well perfused. So the end capillary oxygen tension is also normal, like 20.5 ml per deciliter. Coming to the unit with the reduced ventilation, so this has a VQ ratio of 0.1. So here the ventilation is almost nil, but the perfusion is relatively well perfused. So the concentration of PO2 and PCO2 is similar to the mixed venous blood. So the what are the how are the PO2s and PCO2s in the mixed venous blood? The PO2s are around 45 and PCO2 is also around 45. So if you sample this unit, the end capillary PCO2 is similar to the mixed venous blood, that is 45 millimeters of mercury, and the end capillary oxygen content is around 15.2. Again, it is similar to the mixed venous blood. So the what is the how will the PO2 be in the effluent blood? The effluent blood is a mixture of both the well ventilated as well as the under ventilated units. So here it has an arterial oxygen content of around 17.85. So it is not the mean of the partial pressures of these 2 units, but it is a flow weighted mean of the arterial oxygen contents of these 2 units. So the arterial oxygen content is 20.5, 15.5. That comes to around 35.7 by 2 is the 17.85. So the arterial oxygen content of a effluent blood is the flow weighted mean of the individual units oxygen content. So in case of low VQ units, there will be uniform distribution of blood flow but uneven distribution of ventilation. As a result, low VQ occurs, which decreases the alveolar PO2 and thus lowers oxygen content as well as and the end capillary blood oxygen tension too. The relative overventilation or high VQ ratio of the other unit results in a only slightly increased oxygen content for blood leaving this unit. the oxygen content of arterial blood is determined by the flow weighted mean of the oxygen contents, not partial pressures for blood from different units. And the overall effect of low VQ units is therefore a reduced arterial oxygen tension and an increased gradient alveolar arterial oxygen pressure difference. The effect of low VQ units on PSCO2. What happens to PCO2 in case of low VQ units? The effect of low VQ units on PSCO2 is less compared with the effect on PaO2 because CO2 elimination is increased in the unit with high VQ ratio. So similarly, patients who have hypoxemia because of low VQ units, they respond to increasing, they respond to supplemental oxygen. So increasing FiO2 counteracts the hypoxemia by increasing alveolar PO2. Coming to the next case, case 5, is a 32-year-old male suffering from severe ARDS secondary to bacterial pneumonia. His ABG is like this: pH of 7.28, PCO2 of 61, and PaO2 of 67 with FiO2 of 0.8. So, what is the reason for hypercarbia as well as hypoxia in this case? The reason is shunt. So again, this can be explained by the 2-unit lung model. So on the left, we have a unit with relatively adequate ventilation as well as adequate perfusion. So it has got a VQ ratio of 2. So the encapillary blood is well oxygenated. On the right, we have a unit with no ventilation because there is an obstruction, or it might in case of ARDS, the alveolus might get filled with fluid. So but the perfusion is there, but since there is no ventilation, the VQ ratio is equal to 0. So again, the encapillary of this unit, the PO2s or oxygen content is similar to the mixed venous blood. And finally, when you sample the arterial blood, which is a mixture of both these 2 units, it is above the mixed venous blood, but below the well ventilated unit. So it is around 17.75 mL per deciliter. So shunt can be viewed as one extreme of the range of VQ ratios with a ratio of 0. So the encapillary blood flow from this unit has the same encapillary oxygen tension as well as oxygen content as mixed venous blood, and when combined with blood from the other unit, decreases oxygenation of arterial blood. So again, the arterial oxygen content is again the flow weighted average of oxygen content from the gas exchanging unit and the shunted blood. So how do you quantify the shunt? The amount of shunt is quantified as the fraction of cardiac output distributed to the
రెటినెన్స్ ఇంకా రాలేదు కానీ సిఆర్ఆర్టీ చేయాలి అంటే బాస్కి అనకాపల్లి వెళ్ళారు, శ్రీనివాస్ సార్ ఊర్లో లేరు.
సురేంద్ర మైక్ ఆఫ్ చేయి.
2 non-ventilated units. So the effect on arterial oxygenation depends upon the shunt fraction as well as the oxygen content of mixed venous blood. Why oxygen? The effect on arterial oxygenation depends on the oxygen content of mixed venous blood also, because in case of hypoxemia, we know that tissues extract more oxygen from the systemic circulation, which causes a drop in mixed venous oxygen tension. So since we know the overall oxygenation is a combination of oxygenation from the well ventilated as well as the poorly ventilated unit, the drop in mixed venous oxygen content further decreases arterial oxygenation. So for a shunt of certain magnitude, lower mixed venous oxygen content will result in worse arterial oxygenation. Interventions aimed at increasing mixed venous oxygen saturation and consequently mixed venous oxygen content, such as raising the arterial oxygen content through increased hemoglobin concentration, decreasing oxygen consumption, or increasing cardiac output, might therefore improve hypoxemia caused by a large shunt. So with shunt, like our earlier cases, with shunt, increasing FiO2 is much less effective at improving arterial oxygenation. Why? So this is an iso shunt diagram. So plotted with FiO2 on x-axis and PaO2 on y-axis. So these are the graphs for various degrees of shunt. So 0% is there is no shunt at all. the 50% is 50% of the cardiac output is in shunt. So as you can see, with increasing FiO2, the PO2 continues to rise till a certain degree of shunt, till like 20% or 25%. If the shunt is beyond 30%, increasing FiO2 causes a negligible increase in PaO2s. So that is why with increasing shunt fraction, the effect of raising FiO2 is progressively less, and for very large shunts, even an FiO2 of 1 has little effect on arterial oxygen tension or PaO2. So shunt can be seen in extensive atelectasis, severe pneumonia, and ARDS. So what happens to the alveolar arterial oxygen pressure difference in case of shunt? So here we have 3 kinds of shunt. So this is a 10% shunt, 20% shunt, and 30% shunt. With increasing shunt, the AA gradient keeps on increasing. So coming to the next case, so we have a 67-year-old male, the previous patient only, with severe emphysema. Now she was hospitalized with acute exacerbation of her COPD. And an ABC showed a pH of 7.21, PaCO2 of 85 millimeters of mercury, and a PaO2 of 67 millimeters of mercury. Her minute volume is 12 liters per minute. That is almost twice the normal minute volume. But still, she has hypercarbia as well as hypoxemia. So how do we explain this? So before that, we need to learn about dead space. What is dead space? We all know that dead space is that part of the tidal volume that does not participate in gas exchange. So if that volume is retained in the conducting airways, it is called anatomical dead space. So which corresponds to around 150 ml per 150 ml or 2 to 3 ml per kg of body weight, or 1/3 of normal tidal volume. And there is one more entity called alveolar dead space, which is nothing but alveoli that are ventilated but not perfused. And there is one more dead space called apparatus dead space, like the patient is breathing through an ET tube or having a face mask. So the volume of that face mask or ET tube or breathing circuits constitute the apparatus dead space. So the total dead space is the sum of anatomical, alveolar, and apparatus dead space. And physiological dead space. The physiological dead space is nothing but the sum of these two, anatomical dead space and alveolar dead space. In normal individuals, the physiological dead space is almost identical to the anatomical dead space because the contribution of the alveolar dead space is insignificant. But in disease conditions, the contribution of alveolar dead space becomes significant. So any of the physiological mechanisms contributing to an increased arterial alveolar carbon dioxide difference will increase the measured physiological dead space. But ordinarily, the extent of overall VQ heterogeneity is the most important contributor. In addition, in the presence of increased VQ heterogeneity, any stimulus increasing the overall mean VQ ratios, such as extreme hyperventilation with exercise, will further increase the physiological dead space measurement. So, if there is increase, the hypercarbia is because of increased dead space ventilation in the case of this old lady. So, in case of increased dead space ventilation, the effective alveolar ventilation, which is nothing but the volume of gas per minute that participates in gas exchange, it has to be increased. So, in contrast, dead space ventilation or wasted ventilation is the fraction of total ventilation that does not contribute to gas exchange. The sum of this alveolar ventilation and dead space ventilation is the minute ventilation. So, effective alveolar ventilation can be calculated by this formula. So, an increase in dead space means a greater minute ventilation is needed to maintain effective alveolar ventilation adequate for CO2 removal. So, in this lady, even though the total minute volume is twice that of normal, most of it might going to dead space ventilation. That's why she is her CO2 elimination is not adequate. So, this dead space concept can be explained with two lung unit model. So we have on the left, we have a well ventilated as a well perfused alveolus, and on the right we have a well ventilated unit, but there is no perfusion. So the CO2 elimination in this unit is normal, but here there is no CO2 removal. So As a result, the PCO2 in the arterial blood increases. So coming to the now more than two unit lung models. So gas exchange in different alveoli varies because of difference in their VQ ratios. So the gas exchange in the entire lungs and the resulting PO2s and PCO2s in arterial blood are determined by the effluent blood from thousands of units with different VQ ratios. So to study or to understand the effect of units with varying VQ ratios, Riley and Cornard suggested a three compartment model, a 3-unit model, in which one compartment has an ideal VQ ratio of 1 totally without ventilation, that is VQ ratio of 0, which we call also called as shunt, and 1 without blood flow with a VQ of infinity, also called dead space. So this is a 3-unit lung model. So this is a with perfusion but no ventilation. This is with ventilation but no perfusion. So VQ ratio here is infinity and here is 1. This unit without ventilation is also called shunt or venous admixture, while this unit with ventilation but without perfusion is also called wasted ventilation. This is a normal unit. So in normal individuals, the VQ ratios usually lies between 0.3 and 2, and it forms a bell-shaped curve. So to the left, we have the shunt or the venous admixture, and to the right, we have wasted ventilation or dead space ventilation. Venous admixture. This is also called calculated shunt. So this is responsible for the normal observed difference between oxygen contents of end capillary blood and arterial blood. So to quantify the shunt, if the patient is allowed to breathe 100% oxygen, we can differentiate whether the hypoxemia is due to shunt alone or is it because of low VQ ratios. Because with 100% oxygens, the regions with low VQ gradually improves their oxygenation, while those with shunt won't. So this is the formula for to calculate shunt. If you know the end capillary oxygen content and the mixed venous oxygen content and the arterial oxygen content, you can calculate the shunt. Coming to wasted ventilation, this is also called I'm sorry, this is not physiological dead space. Wasted ventilation corresponds to the total dead space that would cause the observed impairment of CO2 elimination. So measures of wasted ventilation thus estimate the effect of VQ mismatch on the minute volume needed to maintain adequate gas exchange. An increase in wasted ventilation requires an increased minute volume to maintain unchanged effective alveolar ventilation. So to calculate the wasted ventilation or dead space ventilation, we need to know the alveolar PCO2 as well as the mixed expired CO2. But now there are modifications to this equation. Instead of mixed expired ECO2, they replaced it with end-tidal carbon dioxide tension, which almost correlates with mixed expired PCO2. So what about normal lung? Is there any VQ mismatch in the normal lung? Yes, normal lung is does have VQ mismatch. This is because the regional ventilation and blood flow are not uniform in the normal lung. This is due to the influence of airway and vasculatory geometries, as well as regional differences in blood flow and lung compliance due to gravity. In young, healthy individuals, most ventilation and blood flow are distributed to units with VQ ratios between 0.3 and 2. With increasing age, ventilation and blood flow are distributed to units with a wider range of VQ ratios, with blood flow to low VQ regions being attributed to reduced ventilation of dependent lung regions due to airway closure. This is the reason for the increased alveolar arterial oxygen gradient as the age advances. So to alveolar arterial oxygen pressure difference is a sensitive measure of gas exchange when anyone is breathing air. But again, as I said, it is dependent on age. So hypoxic pulmonary vasoconstriction. So hypoxic pulmonary vasoconstriction is an adaptive mechanism to improve the VQ heterogeneity. So what happens is, in case of hypoxemia, this hypoxic pulmonary vasoconstriction comes into effect and it diverts the blood away from poorly ventilated units towards better ventilated units by causing precapillary vasoconstriction. As you can see, the unit on the right has a decreased ventilation compared to the unit on the left. So as you can see, as a result of hypoxic pulmonary vasoconstriction, there is reduced perfusion to this alveolus compared to this, because the blood flow is diverted to well-ventilated regions to improve PaO2s. So HPV improves VQ matching and arterial oxygenation. The efficacy of HPV in correcting VQ mismatch decreases with the extent of hypoxic lung region. And this is of importance only in diseased lungs, because HPV is of little importance for VQ matching in normal lungs. So we'll be talking about a few clinical conditions. The first one is COPD. COPD may present with hypoxemia, hypercapnia, or both. The hypoxemia or decreased arterial oxygen tension is due to low VQ regions, while the hypercarbia or increased PCO2 in arterial blood is explained by decreased effective alveolar ventilation, as I said earlier, because of increased wasted ventilation or dead space ventilation. So the hypoxemia in COPD patients can be corrected by supplemental oxygen. But again, giving too much oxygen causes CO2 retention in these patients. Why? Because the reasons include there will be decreased drive to breathe, and there will be increased VQ heterogeneity, because previously the regions with low VQ now become regions with high VQ. And the third reason is that is proposed is the Halden effect. Halden effect is nothing but increased arterial oxygen tension decreases binding of both H+ ions as well as carbon dioxide to hemoglobin, thereby increasing the PCO2 in the arterial blood. The next condition is the ARDS. ARDS, we all know that it is characterized by severe hypoxemia. So the fall in PO2 in arterial blood is mostly due to shunt, because in ARDS the alveoli are fluid filled, so there will be no ventilation, but there will be perfusion. So low VQ regions are either absent or a lesser cause of low PO2. So what happens if PEEP is applied in ARDS patients? So PEEP has got both beneficial and harmful effects. The beneficial effects include application of PEEP reduces the amount of non-aerated lung tissue through alveolar recruitment, and it improves arterial oxygenation by decreasing shunt blood flow. But again, at the same time, it increases the total dead space. How? By increasing the intra-alveolar pressures, it causes the precapillary closure. Like if you remember the west zones of lung, it increases the areas with zone 3. So that's why it increases the total dead space. And we all know that PEEP decreases cardiac output. So another method to improve oxygenation in ARDS patients is prone posturing. Prone posture decreases shunt and improves overall VQ mismatch. So coming to the next condition, that is pulmonary embolism. Pulmonary embolism is characterized by dyspnea, hypoxemia, increased alveolar arterial oxygen gradient, and normal or even low PCO2 in arterial blood. The hypoxemia is due to increased VQ mismatch, but not due to increased shunt. The high VQ regions are due to regions with no or reduced blood flow. This hypoxemia might be aggravated by circulatory failure causing low mixed venous oxygen tension, or by intracardiac right to left shunting, both provoked by acute pulmonary hypertension. So when you monitor end-tidal carbon dioxide, if there is an increased difference between the arterial and end-tidal PCO2, it indicates increased wasted ventilation, and it increases the likelihood of pulmonary embolism. So to summarize, these are the 5 causes of hypoxemia: diffusion limitation, hypoventilation, decreased inspired oxygen tension, low VQ ratios, and shunt. So in diffusion limitation, the alveolar PO2 is normal, while the alveolar arterial oxygen pressure difference is increased, and it responds to supplemental oxygen. In hypoventilation, there will be reduced alveolar PO2, so the alveolar arterial oxygen pressure difference is normal. This also can be corrected with supplemental oxygen. Decreased inspired oxygen tension again has reduced alveolar PO2, and the alveolar arterial oxygen pressure difference is normal. This can be corrected to with oxygen supplementation. Low VQ ratios. In low VQ ratios, there will be decreased alveolar PO2 in locally. It is not reduced overall. Locally, where there are areas with low VQ ratios, there the alveolar PO2 is reduced, and in those areas the alveolar arterial oxygen gradient is increased, and this can be corrected with supplemental oxygen. And shunt also, again there will be reduced alveolar PO2 and alveolar arterial oxygen gradient is increased. But as we have seen before, with increasing shunt, increasing FiO2 has minimal effect on PaO2. So the take-home message is low VQ regions and shunt are by far the most common causes of clinically encountered hypoxemia. Hypoxemia due to shunt characteristically responds poorly to increased FiO2. Effect of hypoventilation and low VQ regions on CO2 removal is less and modified by the ventilatory response to hypercapnia. High VQ regions and alveolar and apparatus dead space increases wasted ventilation. The primary response to increased wasted ventilation is increased minute ventilation and work of breathing, and not increased PCO2 in arterial blood. So by using alveolar arterial oxygen pressure differences, venous admixture, wasted ventilation, the effect of VQ mismatch on gas exchange can be quantified. Thank you.
Thank you, Suresh. Very nice presentation. Explained all types of VQ mismatch and pathophysiology and various conditions where hypoxemia or hypercarbia are happening in different diseases. My question, one question is there. You explained at the end of hypoxic vasoconstriction. So that is not happening in
Normal
COVID patients. COVID patients.
COVID patient.
So can you explain that pathophysiology?
See, again, this here I have mentioned that. So the efficacy of HPV in correcting VQ mismatch decreases with the extent of the hypoxic lung region. So if the extent of hypoxic lung region is extensive, so the efficacy of HPV is very limited. So that might be the reason that you have seen COVID patients. We all know that they have extensive lung disease or extensive disease. So HPV is of little importance if such extent is seen.
That is why patients are not having breathlessness, even saturation is coming down to 50 or 40 also.
మళ్ళీ చెప్పండి ఒకసారి.
Sir,
Suresh.
if the extent of the hypoxic lung region is extensive, the efficacy of HPV in correcting VQ mismatch or the efficacy of HPV in improving arterial oxygenation is limited.
Like anesthesia. Whenever anesthesia gives the patient HPV goes away, no?
Anesthesia, it is not documented, sir. If the patient is on inhaled vasodilators, then the effect of HPV is abolished.
Okay. Normally for our inhalation anesthesia, they say no, it's HPV goes in anesthesia time whenever we do. We have, I think in the physiology, is it right? I don't know. Somebody can correct me. Normally we read like that in anesthesia, when we give anesthesia, HPV has been abolished.
Hypoxic vasoconstriction will be lost in anesthesia, under anesthesia?
I don't remember, sir.
ఎవరికైనా గుర్తుందా? Anybody?
నాకు అలా గుర్తుంది సార్, తప్పు రైట్ తెలియదు.
ఎవరికైనా గుర్తుంటే they can explain.
రమణ ప్రసాద్ గారిని అడగాలి.
And one more reason for loss of hypoxic vasoconstriction in COVID patients, they have both extents of ARDS and also they have pulmonary coagulation. So these vessels are also blocking due to the increasing the coagulation. So the effect is lost because already the vessels are also blocked due to clotting.
Okay.
That is the both reasons are worsening the
That
hypoxia.
increases the dead space ventilation.
Yeah,
Because,
increasing dead space ventilation. So there is no
Okay,
vasoconstriction.
teacher Chandra, Shekhar, or Varalakshmi, somebody. Is it in anesthesia? Koncham abolish avutuda? And Chappandi, anybody knows? Manjula, professor.
Yes, sir, there is abolition. ఎందుకంటే most anesthetic agents are vasodilators కాబట్టి both inhalational and IV. So there is HPV is inhibited. That is one of the reasons why patients become hypoxemic during anesthesia.
Is it effect of nitrous oxide, Varalakshmi?
Not only nitrous oxide, sir, all inhalational agents and IV agents also, because they cause vasodilatation as a side effect. So there will be inhibition of HPV, sir.
Yeah, in nitrous oxide, when I remember, it causes more of HPV.
Okay.
Very nice explanation, Dr. Suresh.
Thank you.
And one more thing, Suresh.
Hey, good morning.
I think somebody else taking something.
Yeah, please.
Sir, morning, sir. So this anesthesia drugs, is it also associated with pulmonary vasodilatation? Only intravascular vasodilatation అయితే ఉంటుంది. Pulmonary also is contributing.
Pulmonary also, నాకు తెలిసి, I don't know, maybe I forgot.
Yes, sir, they are also pulmonary vasodilators.
కరెక్ట్గా గుర్తులేదు బట్ చాలా మంది ఉన్నారు కదా మన అనస్థిస్టులు, పీజీస్ ఉండాలి కదా, ఎవరు లేరా?
Sir, నేను ఒకసారి refer చేసి I'll put an article or something, sir, but I mean, I'm almost sure that there is inhibition of HPV.
Sure.
Yeah, there is inhibition, sir.
Chandana kada?
Avun sir. That is what we have in exam questions also, sir. HPV
Yeah, I
is
remember.
decreased.
In much more
Yes, sir.
anesthesia, but I don't want to be sure about it. I'm not sure. That's why.
Yeah, yes, sir. Yes.
One more question, Suresh.
Sir.
In ARDS patients, particularly in COVID, severe ARDS, the oxygen dissociation curve, as you said, that is a sigmoid shape, and once it is fall below 60 PO2, SPO2 drastically declined.
Yes, sir.
Okay, but if you take the PO2 of PO2 is 45 or 50, corresponding SPO2 will be around 80, 85.
Sure.
But in case of ARDS, it is around 90, above 92. Is there any reason for that? Any shift of curve?
Sir, I don't understand, sir.
If PO2, if corresponding PO2, so see this PO2 relation.
Sir.
See, this saturation is around at
The
the
PO2 of
level
100
of
milligrams
60,
of mercury, the corresponding saturation is 100%, sir. Arterial
100.
saturation.
Around 60.
So around 60 of PO2.
Yeah, PO2, SPO2 will be
SPO2 will be around
90.
85 or 90.
Yeah, 90. But in ARDS, even if it is 45, 50, the SPO2 may maintain around above 90. It is not corresponding to this curve. Exactly not showing the relationship with the curve. Is it because of the shifting the curve?
No idea, sir.
Yeah, it is there. But I remember this thing, but exact reason I forgot. Even if PO2 is coming down to 45, 50, the corresponding SPO2 will not go down very severely. Like if it is 45, 50 PO2, corresponding SPO2 may be around 75, 80, but it will maintain about 90 due to shifting the curve.
Okay.
The exact pathophysiology, it is happening in COVID patients.
Okay, sir.
I will put that message if I remember.
Okay.
Any questions?
Sir,
Thank
good
you,
morning,
Suresh.
sir.
Nice presentation.
Thank you, sir.
Suresh sir, one question, sir.
Sir.
Good morning. Which is the site to get mixed venous blood sample? Best site.
Best site is catheterizing right heart, sir, and sampling from RA. But that is too invasive.
సరే జుగులార్ బల్బ్ ఉంటది కదా సార్, అక్కడ నుంచి కూడా తీస్తారు కదా సార్. I don't remember exactly. SG wave.
That doesn't include venous blood coming from lower
Yeah.
extremities.
Yeah, lower extremities.
Sir, I think it is
పల్మనరీ క్యాథెటర్ తీసేది కదా.
pulmonary catheter. I
పల్మనరీ
think that
క్యాథెటర్
is
నుంచే తీస్తారు. అవును సార్.
Pulmonary artery is the best site.
pulmonary artery.
Pulmonary artery is the best site. But sorry.
సార్ ఇంకొకటి ఇది కరు చెప్తున్నారు కదా సార్, అది
Difference ఏంటంటే usually we follow taking central line because usually the difference is between approximately around 5% between CVP and then jugular and pulmonary artery. But in sepsis cases, they found to be difference is very large between these two things.
Okay, sir.
Yes, please go ahead.
CVP line when we place, they will only right ventricle. They'll cross the right rim and then they are in the right ventricle. Because when we push like almost 15 centimeters, they are all nowadays available as 13, 16 centimeters. When we completely introduce, they are in the ventricle only. I think.
What is completely introduced? CVP line?
Central line.
Will it go to RV? May not be, no? We don't know. Depends on the size of the patient. Or we put posteriorly a very low level and push the 16 centimeters completely. May, but no guarantee for that. ఏమైనా questions ఉన్నాయా? We have 5 more minutes time. When you will see increase in this delta carbon dioxide, Suresh? The difference between the EtCO2 and PCO2. When it will be high?
Like when there is a likelihood of pulmonary embolism, or microemboli causing increased dead space ventilation.
Okay. The delta PCO2 will be high.
High.
Right.
Sir, you mean to say arteriovenous carbon dioxide difference, huh?
Arterial and tidal.
Sir,
Sorry, అదే EtCO2 minus PCO2.
EtCO2 minus EtCO2.
PCO2 minus EtCO2.
Okay.
And one question, residents. If post-operatively patient shifted to ICU, patient is drowsy, arousable, but slowly after 1 hour you will get a call from the sister that saturation is around 89-90. Will you go oxygen supplementation or will you do ABG or will you? Hello? Will you do ABG or will you do oxygen supplementation only, or will you put the patient on NIV, or will you intubate the patient? And what is the reasons? Residents ఎవరు ఉన్నారా?
అసలు రెసిడెన్స్ ఏం క్వశ్చన్ అడగారు సార్, మీరు అడుగుతుంటే భయపడిపోతున్నాడు.
అడిగిన దాన్ని చెప్పకపోతే అడగొచ్చు మానేస్తాం సార్ మరి.
అయ్యా అలా లేదు సార్, మాట్లాడమని చెప్పండి, తెలియదని చెప్పనండి వాళ్ళని.
అదే ఇప్పుడు ఆ క్వశ్చన్ అర్థమైంది కదా. పేషెంట్ షిఫ్టెడ్ టు ఐసీయూ పోస్ట్ ఆపరేటివ్లీ అండర్ జనరల్ అనస్థీషియా ఎక్స్టుబేటెడ్. After 1 hour or 2 hours, you get the call that the saturation is around 88, 89. And the sister told that I put the oxygen mask. After that, saturation improved to 92, 93. What if you get the call at this stage? What you will do? You will say, you will said that okay, it's okay, leave it like that, or will you do ABG? If you want to do ABG, why you want the ABG? Or you put the patient on NIV, or you want to intubate the patient, and give explanation for each answer. Hello, sir.
ఎవరున్నారమ్మా అక్కడ స్టూడెంట్స్ లైన్ లో?
స్టూడెంట్స్ లేరా మనకి మూడు ఇక్కడ ఇయర్లో? సార్ ఎవరు?
సార్ ఉన్నాం సార్.
మాట్లాడండి ఏదో ఒకటి, లేదంటే తెలియదు సార్ అని చెప్పండి.
లేదు సార్, పోస్ట్ ఆపరేటివ్లీ when the patient is prematurely extubated or the reversal is inadequate, there can be bradypnea sometimes, or lack of respiratory efforts, so there can be PCO2 retention. We have to do an ABG, sir, and see how the blood ABG is, and according to that we have to act.
So usually what you will get, what will be the abnormality in ABG?
High PCO2 levels, sir.
Okay. Then once the PCO2 increases, PO2 also, you show the curve, no? Once PCO2 increases, PO2 according to the alveolar gas equation.
Yes, sir.
Once PCO2 increases, PO2 will come down.
Yes,
due
sir.
to hypoventilation.
Yes, sir, due to hypoventilation.
Yeah. What you will do for that?
We have to intubate the patient, sir, and ventilate till the PCO2 level comes down, and then the patient, once he regains consciousness and efforts are good, then we can extubate the patient.
Is it mandatory intubation, or can you manage any other modality? Patient is drowsy, arousable.
Yes. Drowsy, arousable, sir. We can try. Yeah, if the patient is like verbally responding, we can ask the patient to take deep breaths. But because the efforts are not there, we can probably try NIV for some time.
Yes.
I've not used NIV much, sir. Generally, usually if we get a call, I have intubated the patient and extubated.
Anna, Satish wants to tell something.
Why are we only looking into the post-operative to incomplete recovery? Is there any other possibility to evaluate different varieties of hypoxemia in this patient? We are only looking into incomplete recovery, bradypnea or hypoventilation, then, and almost like we have come to a conclusion that this, but we need to evaluate it, troubleshoot it. Why the patient is hypoxemic, and why there is desaturation which was not there, which happened half an hour after the surgery. What are all other possibilities that lead to hypoxemia? We need to troubleshoot in that way.
Definitely, hypoxia troubleshooting must be there. But the most commonest cause is post-op hypoventilation, drowsy, all these things. Next, you can go to other causes. Most common cause, next to further other causes. Because we are regularly seeing this type of.
సతీష్ చెప్పేది మెడికల్ కేసెస్ కదా, అంటే అనస్థీషియా పోస్ట్ అనస్థీషియా కాకుండా మెడికల్ కేసెస్ కూడా ఉంటాయి కదా. నువ్వు చెప్పేది గులెన్ బ్యారీ సిండ్రోమ్ అలాంటి వాటి గురించా సతీష్?
కాదు సార్,
అదే కాదు సార్, అదర్ రీజన్స్ కూడా ఎత్తకమంటున్నారు సార్. లైక్ లంగ్ ఇష్యూస్ ఏమన్నా ఉన్నాయా, లేకపోతే సిఎన్ఎస్ లో ఏమన్నా స్ట్రోక్ వచ్చిందా, వై ఇస్ హీ ఆర్ హర్ షీ హైపోవెంటిలేటింగ్ అన్నది చూసుకోవాలని.
Definitely, I will give one example. Recently we had one case. Post-operatively, patient developed severe hypoxia. Immediately, patient within 5 minutes had cardiac arrest. So immediately intubated, and started ventilation, saturation is picking up, and again ROSC within 5 minutes. So once you go to the, as he said, evaluate the patient troubleshooting. When you did the echo, there is a severe LV dysfunction. This happened almost 10 days back. Severe LV dysfunction, EF is around 15-20%. Before surgery, echo was normal, ECG also normal, 77 years old female. Severe LV dysfunction. So, yeah, not only post-op respiratory depression, not only muscle problem, conscious problem, there must be some other reasons. Particularly old patients may develop a PE, pulmonary embolism, one of the more common, one of the reason, and MI, intra or perioperative MI, severe LV dysfunction. So many reasons will be there. You can rule out, troubleshoot this hypoxemia. Chepana.
Similar, sir. We also had a patient, a young patient, 20-year-old patient, posted for a test, and patient came to ICU.
Yes.
At the time of just finishing the surgery, the patient had SVT and shock, hypotension. So the patient came to ICU. We intubated the patient. Patient EF is only 15 to 20%. So vasopressors we started and butamine also, inodilators, and later we thought we'll put an IABP. And as the patient is an ASA grade 1, doesn't require to be evaluated. So is it a DCMP previously, or we don't know the cause? But the patient improved in 2 days and we extubated, and at the time of discharge, the cardiac function is normal. So
was it stress cardiomyopathy?
Yes, sir. Yes, sir. Yes, sir. But usually these all what we see in the textbook description will not be seen on the echo also in this patient.
Right. Okay. Anna, Satish, no hand lift చేసావు.
Mohan sir అడిగారు కదా. See, scenario is the same. As you understand, that is very limited. Like patient is post-operative, half an hour of that and desaturated to less than 90%. So obviously we need to go with a hypoxemic algorithm. But clinically we see that when the patient has a sustained head lift for more than 10 seconds and then all the muscle power is adequately maintained, so the chances of thinking of towards going into neuromuscular blockade is relatively less, rather than we have to look into the other physiological aspects that is causing hypoxemia. It can be a cardiac reason, it can be a respiratory reason. So troubleshooting, the steps need to be organized in these patients. We cannot just click on to one diagnosis here. We have to have a clinical examination, then ECG, then chest X-ray, then ABG, look into the AA gradient. And if AA gradient is well maintained, it is like respiratory, like neuromuscular issue or some obstructive issue. If AA gradient is worsening, it is a shunt fraction. So this is how we need to go into and troubleshoot the hypoxemia in that patient.
That's why I asked her what is the role of ABG. She said PCO2, no? Yes. Another reason she has to tell that what is the other reason, madam? ఇందాక ఎవరు రెస్పాండ్ అయ్యారు కదా ఎవరు
arterioalveolar
gradient. Yes. What will be the gradient if it is a respiratory depression? Hypoventilation, in post-op hypoventilation due to sedation or whatever it is. Will it increase or decrease or normal?
Normal A gradient ఎంత సార్?
Around 10.
5 to 10 maybe. Yeah, less than 10.
Age factor correction is there, sir.
As per the age కదా.
Age. ఎంతమ్మా ఏ gradient? If it is respiratory depression or due to sedation, patient become drowsy and become hypoventilated, what will be the A gradient? ఇందాక అమ్మాయి ఎవరు రెస్పాండ్ అయ్యారు కదా
తృప్తి అనుకుంటాను.
చెప్పమ్మా.
Age plus
35
plus 10 by 4.
That is okay, but what could be the area gradient in post-operative hypoventilation? What could be the reason?
Then is neuromuscular issue.
అదే గ్రేడియంట్ ఎంత అని అడుగుతాను అమ్మాయిని.
అదే
ఎంత ఉంటుందమ్మా? Patient had hypoxia and you did ABG. Okay, PCO2 is around 65. PO2 around 50. What is the AA gradient in the, what you will expect in that patient? AA gradient will be normal, no?
Normal.
Because the patient is having a respiratory depression, gradient will be normal, lung is normal. So gradient will be normal.
Right, 9-7.
Okay, Suresh.
Thank you, sir.
Very good talk, and it must be necessary for all the students and even consultant also to understand the hypoxemia, hypercarbia, and pathophysiology of various conditions patients are going to hypercarbia or hypoxemia or hypoxia. It is refreshing once after a long time. Thank you for very good presentation.
మాకేం రిఫ్రెషింగ్ కాదు సార్, మేము నేర్చుకుంటున్నాం.
అదే సార్ నేర్చుకున్నాను తెలిసిందని మళ్ళీ ఇంకోసారి రిఫ్రెష్ అవటం అంతే.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you very much. Thank you all for your active participation. Thank you.